Good morning, everyone. Good afternoon or good evening. Thank you for joining us for the overview of the updated WH guidelines on health workforce development, attraction, recruitment, and retention in rural and remote areas. I'm Nicholas Torres, Executive Director of the Network Towards Unity for Health, and we're happy to host this event with WHO. I just wanted to acknowledge, a couple of our board members. We have our General Secretary, Elsie Kiuli Mawadi, with us, and Nijat, and also one of our partners with PAHO WHO is Jose Francisco. Thank you for joining us. We also have Bjorg from our board members. These series, TUFH has been doing, as you know, we have an annual conference where we bring the globe together to talk about important health issues. And within the last 2 years, we started these bi-monthly symposiums, in which case we could share this information, not only once a year, but on an ongoing basis. And with that, we're very happy and honored to be part of here with WHO. And I would like to turn it over to Bruce Chater from Wonka Rural, because we did a 13-part series in partnership with Wonka Rural on retention. So we'll hand it over to Bruce for a few welcome comments, and then we'll get right to our keynote. So Bruce.
Thanks, Nick. It's a pleasure to be with you from rural Wonka, and also it has been a great collaboration with Towards Unity for Health on the lecture series of our 17th conference. I think we've got a lot in common. We bring frontline rural health workers, and particularly doctors and civil society, to the table. Obviously, it's a great collaboration with you, and particularly the academic side more broadly. We certainly look at the rural academic side, and then obviously WHO with the policy side of things. So from that lecture series that we did together, we got a blueprint for rural health, which I think is a great synergy with what WHO has just produced. And there's lots of common things and common themes, which I think will come out tonight. From our lecture series, we had a real emphasis on advocacy and policy, education in place in rural areas, fair remuneration and conditions for workers and people working to their full potential. And I think we'll hear a lot of those themes tonight. And we certainly as a group look forward, Nick, to working with you and Michelle very much as we have with WHO over the last few years, continuing a great partnership. So looking forward to tonight and taking this forward for the good of rural people who we live with and serve. So thanks, Nick. Back to you.
Thank you. So now I have the honor of presenting Dr. Michelle McIsaac, who joined WHO in 2016. She is an economist in the Health Workforce Department, where she leads WHO's work on gender and equity in the global health and care workforce, including work on geographic inequities, the rural and remote health workforce, and analysis of national health labor markets. Michelle will present. We will then have some open questions, and then we will have breakout groups with some 3 guiding questions for you to interact with each other and answer those questions. So let me turn it back to Michelle. Thank you for joining us.
Thank you, Nick. Thank you, Bruce. It's a pleasure to be here, an honor really to be here presenting this guidelines. It's very exciting and serendipitous as we've just managed to launch the guidelines this very week. And we have a new space on the website as well with some of the materials that we have that will be linked to later. We wanted to start this session with a little video that's been produced by Rural Seeds that really takes together the kind of collective nature that's needed to really address this problem and summarizes more eloquently and more quickly and more beautifully than I can. So we thought we'd have the quick 3-minute video by Rural Seeds, and then I will give you your standard presentation. Please do play the video.
Why do we need rural health workers? Did you know that almost half of the world population lives in rural areas? This includes populations that live near rivers, in forests, deserts, islands, mountainous regions, and other remote areas.
8 out of 10 people living in extreme poverty live in a rural area. More than half of the people living in this area are without adequate access to
Yet, rural health and access to health services are often ignored in analyses of health status and health system performance. Universal health coverage cannot be achieved without a well-trained, motivated and supported rural health workforce.
Addressing the maldistribution of health workers in countries is key to addressing the pervasive inequity in access to health services in rural areas.
So, what can be done?
Within a primary healthcare approach, health workforce policies and strategies play an important role in not only ensuring better health outcomes, but also in driving community engagement, gender equality, and sustainable economic development.
There is a clear need for a whole of society approach to develop, attract, recruit, and retain health workers in rural and remote areas.
We must invest in development and training of multidisciplinary fit-for-purpose rural health teams.
Enrolling students with a rural background in health workers' education programs, bringing students in health worker education programs to rural and remote communities, having health education facilities located in rural areas, and aligning their education with rural health needs.
We must protect and support the existing rural health workforce by giving them decent conditions to live and work, with access to continuing education, professional development, and attractive career pathways.
It is also important to recognize the contribution of this workforce. To guarantee and ensure healthy lives and promote well-being for all at all ages, we need to have policies to develop, attract, recruit, and retain health workers adapted to the unique realities of rural and remote areas.
The newly updated WHO guideline on health workforce development, attraction, recruitment, and retention in rural and remote areas offers a broad view of what can be done to achieve the global principle behind the 2030 Sustainable Development Agenda and to leave no one behind.
So let's think and act in rural areas
Together.
Great. So that is the video that gives the sort of high level overview of the guidelines. I think for me, what's so poignant about the video is the kind of collective nature of voice that you hear coming through the video. And I think this is a really important element in this updated guidelines. And to start, I just wanted to acknowledge first and foremost, because I tend to talk a little bit long and I'm sure that I'll be stopped at the end, but just to say my gratitude to all of those who contributed to this guidelines. Guidelines are an immense amount of effort and require lots of hands on deck. So I wanted to thank the steering group, some of whom are on the call, the guideline development group, some of whom are on the call, the external review group, the enormous amount of volunteers who handled the systematic review, and all of those who have contributed to the work and the research that's the foundation to evidence-based guidelines such as these. So firstly, I wanted to just focus a minute on the guidelines title. So for those of you who've been paying a lot of attention, you'll remember that the 2010 guidelines title was a guideline around improving access through improved retention. And you'll see that this is more of a mouthful of a guidelines title for development, attraction, recruitment, and retention. And this was a really explicit choice to ensure that we're covering the whole spectrum of what we're talking about when we're talking about developing, attracting, recruiting, and retaining health workers in rural and remote areas. It's not just about one of these elements. It's really about holistic policies that look at this from the widest net and think about it from this perspective of all of these areas, not just retaining health workers in rural areas or recruiting them, but really ensuring that those rural areas are attractive jobs for rural health workers, that we're thinking about how we're developing and training health workers who are fit for purpose, who are fit for the rural health needs and taking those into account. So it's really a holistic guidelines that's looking at all of these different componentries together. And it's quite interesting because 2021 is the International Year of the Health and the Care Workers. And the vision of the guideline aligns very nicely with the vision for 2021 with the theme. So the idea is that we need to invest in rural health workers for their development, their attraction, the attractivity of those jobs in these areas, and the recruitment. And we need to protect those health workers who are currently already in rural and remote areas and ensure that they're having decent and safe work conditions. So some of this was highlighted in the guidelines, or in the video that we just produced, or that Rural Seeds has just produced and we have just played. What we know is there's questions around why do we focus on rural and remote areas? You know, why not just looking at effective coverage gaps? Well, one of the main reasons is that rural and remote areas have almost half of the world's population. So this isn't a niche topic. This is a topic which affects 1 out of 2 of all of us around the world. So it's a very important issue just from a numerical standpoint. We also know that there is a huge amount of inequity in access to health workers in rural remote areas. And when we look at it, what we see is there's an estimated 2 billion people around the world who do not have access to the essential health services that they need. These are rural people around the world who do not have access. So this is a really, really, really big problem that affects a lot of people. So it's not a niche problem. This is a problem for everyone. This is a global problem at a global scale. And in addition, it's important to point out that these areas contain some of the world's most vulnerable populations. So we know that almost 80% of individuals who are living below the poverty line are located in a rural remote area. We know as well that rural communities are often socially or culturally distinct. And I think Ian Cooper might be on this call, but he's has a very eloquent way of putting it around the place is important to how people link with the factors that influence how they live. So it's not just about rurality for being different than urban, but rurality for what that means socially, what that means culturally, what that means economically, and really looking at it from that. So this, since the first iteration of the guidelines, many of this hasn't changed. We've still seen high prevalence of rural populations. We've still seen gaps in coverage. We've seen high levels of certain social and economic outcomes in rural areas. But some things have indeed changed. For instance, the first iteration of the rural guidelines from WHO were developed during the Millennium Development Goal era. And during this MDG area, there was a clear relationship that was built between health workforce density and distribution and the achievement of global goals, particularly around health outcomes goals. But it wasn't implicit within the MDGs. And the SDG era, which we are now operating in, has explicitly integrated this into the SDGs. Particularly, we have SDG indicator 3.3C1, which is health worker density and distribution. So this is a part of the global goals, an actual integrated part of the global goals. Plus, what we've seen is there's a very clear link that's being drawn across the achievement of various other global goals when we are adapting policies to address access in rural and remote areas. With 8 out of 10 of the world's most poor living in rural areas, this has a clear link with SDG 1. We know that 5 out of 17 of the recommendations in the guidelines are around education. So there's a clear link to the education goals. There, we know that 7 out of 10 health workers are women. There's a clear link to women's economic empowerment and gender equality. We know that there's a need for economic diversification in rural areas. There's a clear link there, and around reducing inequalities within and across countries. So over the decade since the last iteration of the guidelines, or the first iteration of the guidelines, we've seen more policies enacted to address geographical imbalances in the health workforce. We've seen a lot more evidence on their effectiveness. We've seen data and evidence has increased in this. So the 2010 guidelines were based on 27 studies. These updated guidelines incorporate studies from 133 studies. So a huge increase in the evidence base over the past decade. We know that many more occupations are covered in the guidelines. So in the first iteration, 7 out of 10 of the studies were on doctors. Now we have that around 50%. And then the health worker occupations covered are different, as well as 40% of the studies included in this guidelines are from low and middle income countries. So we see a huge change in the landscape of where we're getting the evidence from and what the basis is. And then there's also been a really clear recognition that primary health care is fundamental to achieving universal health coverage. And then we have the high-level political declaration on universal health coverage as well. So there's lots happening at this global level, and the seeds are really sown. And that's why it's really a crucial and important time for this guidelines to be developed and launched. So let's discuss a little bit about what the guideline is. What we've seen through this additional evidence is that there's a really complex interaction on factors that are affecting access to health workers in rural and remote areas. And that the evidence suggests that there's a strong argument, a very strong argument to be made for bundling interventions. So this is that no one single policy alone can be the resolution to this. This is really an approach that has to understand that this is a complex natured issue that needs complex integrated responses. So the key message coming out from the guidelines is clearly that the interventions need to be interconnected, bundled, and tailored to the local context. So this is the key outcome of the guidelines. It's the overarching good practice statement, and it is really the foundational change that you'll see coming through the guidelines. The other really, really important elements that string throughout the whole guidelines is that community and stakeholder engagement is key, and that whole of society approach is really, really important. So when we're talking about what bundle, we need to think about context. Not all rural communities are the same. Not all remote communities are the same. And we really need to be thinking about what is feasible in that context, what's relevant in that particular context, how affordable is any given policy or bundle of interventions going to be, how effective, and can we expect to see the impact? You know, not just impact in terms of improving densities, but impact in terms of improving health outcomes, in terms of improving economic and social indicators and outcomes. So really, we're thinking about this in a way that we can really encompass all of these different additional issues. Now, this is the kind of key thematic for the discussion and the questions that we have for the dialogue that we're having with you here today. And this is around dialogue and action. So how do we select an appropriate bundle of strategies in a context? We need to be thinking about this from a whole of society approach. We need to be thinking about this from a whole of government approach. So having all the different national authorities that have a relevant role to play, you know, at the table and discussing these policies, taking ownership of these policies, and seeing why these are important. Sorry, did I go muted?
You did.
Am I back? Sorry. So a holistic government approach, as well as a whole of society approach, bringing all the different players to the table. And then that this entirety really affects the strategies that encompass the investment in rural health workforce and the protection of rural health workers. So if we have time, we'll quickly go through the actual recommendations. But we won't go through them in very much detail, because I think really what we want to be talking about is how do we think about contextually relevant bundles, what needs to be in them. There are 5 recommendations that we put under the umbrella of education. And this is, all of the recommendations in the guidelines are conditional or strong recommendation. Conditional recommendation means that we really need to be thinking about context in that particular area. Strong recommendations are those that probably fit more nicely in most contexts, but you still need to be considering that. The first is to enroll students with a rural background in health worker education programs. The second is to locate health worker education facilities closer to rural areas. The third is bringing students in health worker education programs to rural and remote communities. So this is rural exposure within training. The fourth is aligning health worker education to rural health needs. So this is ensuring that the rural health workers are able to work in rural and remote areas and have the skills that are needed in those communities. The fifth is around facilitating continuing education for rural and remote health workers. And so these are the education recommendations that are coming out of the guidelines. And most of them are coming out at very strong recommendations, and there is a fair amount of evidence that underpins many of these recommendations. The next umbrella is under regulation. So the regulation recommendations are all coming through at conditional strength. So that context is really important when we're talking about regulation, and that is intuitive. This is enabling rural health workers to enhance their scopes of practice to better meet the needs of the communities, to expand the range of health worker occupations to meet rural health needs. So these are adding and developing multidisciplinary fit for purpose rural health teams. Ensuring that compulsory service, if you have compulsory service in your context, that this compulsory service is respecting the fundamental rights of health workers, and that they're done in a way that's accompanied with the support that's needed and incentives that are needed. So there has to be adequate working conditions and adequate motivation and support in these arrangements if they pre-exist in your context. The last one in the regulation is to tie education subsidies for rural health workers to agreements for returns of service in rural and remote areas. So the next set of interventions, well, there's a single intervention on incentives, which is a strong recommendation around providing a package of attractive incentives. So these are incentives, of course, they're financial incentives, but there are other incentives as well that could help to influence the attractivity of a rural or remote area. And then the remainder of the recommendations are all around personal and professional support. So the personal professional support is around working conditions, it's around safety, it's around decent work, it's around attractivity. There is recommendations for improving the living conditions in rural and remote areas, ensuring that workplace safety in rural and remote health facilities is there to ensure that there's safety and security in rural and remote areas, which often have health workers who are working alone or working in context. So it's a really important element. Ensuring decent work for health workers in rural and remote areas. So the working conditions are a key element who are coming out in here. And this is something that Bruce was saying at the top. Fostering the creation of health workforce support networks. Developing and strengthening career pathways for rural and remote health workers. So this is ensuring that there is career prospects in rural and remote areas. Facilitating knowledge exchange between health workers. So this is professional associations or other associations that have a rural focus on them. And raising the profile of rural health workers. So ensuring that the work of rural health workers is recognized. And all of these are associated with improved access to health workers. All of those recommendations. Just to end and to launch off to breaking out and having a discussion, we think that it's a really important opportunity right now in the year of the health and the care worker, in a year where we are seeing so much around COVID-19 and lack of access and interconnectivity of all of what we're doing to be investing in health workers and supporting them and protecting them, that the Sustainable Development Goals as a whole cannot be achieved without due consideration to rural and remote populations, that unequal access to health services not only jeopardizes health outcomes, but it also jeopardizes health security, the resilience of our international health systems, and it influences socioeconomic outcomes and development, particularly through as we're recovering from COVID-19, and that there's a big opportunity right now to be investing in rural health jobs, empowering rural health communities, and particularly many of these jobs will go towards women and youth. And so it's a very important opportunity for us to be thinking about this at the moment. So with that, I will allow the participants to ponder on some of the questions around community engagement, on some of the questions around integrating and bundling. Thank you.
Thank you, Michelle. We have a couple questions coming in for the chat box. First question is, what is WHO doing for network in remote and rural area rural area internet?
Pardon?
What is WHO doing in the sense of access to the internet for remote areas related to health?
Yeah, I mean, that's a really important question. So I think one of the things is there isn't an explicit recommendation around an e-work approach or something like that within the recommendations. And access to infrastructure, including the internet, is a really important one that shows how integrated any of this could be. So if you have an approach where e-work or where we're doing m-health, that can't go if you don't have the appropriate internet infrastructure in place in that area. So how can you be having a health policy and a pillar like that if you don't have the infrastructure and you don't have the governments, the side of the governments that are looking at this at the table? So I think it's really important to point out that many of these issues are not issues that fall within the remit of one particular ministry, but that we really need to be thinking about a holistic whole of government approach when we're looking at this, because that's the only way that we can address the kind of complexity that's involved in that.
Next question is, the recommendations are wonderful. However, in a country with a decentralized system where local government has a powerful position, how do you think to make these recommendations doable? And in context, local governments depend upon local elections so that they are unstable.
Yeah, that's a tough one. I mean, I think that one of the main things that the main thematics that come out of the guidelines is that there isn't a one size fits all approach. So it's not that this can be, you know, a decision that's made here and then it trickles down and it has to be adopted at the local level, but more that it's sort of the bottom up approach where you're looking at within any given, you know, country, there could be different bundles that are needed for different contexts. And then that would really take the leadership from that local government who needs to be taking this. In terms of political cycles, this is a real challenge for many, many health issues. This one included, how do we ensure that that doesn't affect, you know, what decisions are made is a huge challenge. Yeah. And not one that I have the answer to.
So we're going to do a couple more questions and then we will do breakout groups. And I'm going to state this as is. I'm not quite sure if I understand it, but it says, could you explain how the classification for strength of recommendation and certainty of evidence for each guideline?
So the strength of recommendation is one that talks about is the recommendation a strong recommendation or a conditional recommendation? So strong recommendations are recommendations that that are more applicable to most contexts, and conditional recommendations are one where we need to think about some of the more nuanced implementation considerations in the context when we're adopting it. So this might not be something that would be applicable to every context, but you know, this is what's important. And then the evidence. Now this is complicated for health systems guidelines because health systems guidelines, they follow the same approach that's used for all guidelines and health guidelines. And so the evidence is held to a standard that's the same that is the evidence for health guidelines. And so where the gold standard would be a clinical trial of sort of element. And so health systems guidelines are never going to have that same level of certainty that you'll see in health guidelines. And so sometimes you might see where you might have something that's rating as a lower certainty of evidence, but that could still be a huge number of very good studies that aren't clinical trials, you know, that are leading to the evidence. And that's why you would still see a strong recommendation, one that we're sure can be applied to many contexts, even if you have a low certainty of evidence, because you have a strong number of best in class, best possible studies that are influencing that.
Well, thank you, Michelle. We're now going to send everybody into breakout groups. We have 3 guiding questions that we want you to consider in these groups. Is how do we strengthen advocacy for equitable access to health workers in rural and remote areas? 2 would be, how do we strengthen partnerships to ensure rural research mainstreamed in health systems and health outcomes research? And the 3rd is, how can communities be better engaged in policymaking in rural and remote areas? In your breakout rooms, we'll repost these, but so you have them. And now we're going to send you for breakout groups for approximately 15 minutes. In your breakout groups, if there's one person that will have a brief of 30 seconds or so brief reporting back. So if there's one person in your group that could report back, that'd be fantastic to keep the conversation going when we reconvene. It looks like we're all back. So we're going to do a quick round by room or by breakout room just for some summary before we launch back into the main discussion, and have Michelle do some commentary on some of the feedback, and also with Bruce. But the first group was, I'm not sure who's reporting back, but with Bjorg, Bruce, Catherine, Gavin, Jim, Marlene, Michelle was in that, Senkina and Thomas. who would like to report back?
I can report back for you, Nick. We had a good discussion around particularly local action, and that local action can be very effective, that the partnerships between health workers and community leaders is important, that local education of those community health workers and the other health, not only community health workers, but health workers more generally, is important, that using the data that they're collecting already to be research is important, rather than having necessarily high-level research, just looking at the practical things and being able to share and publish some of that. There's some discussion around local competition between communities, and in fact, that can be a positive thing sometimes for the politicians to have to step up and show that they're a bit better than the politician next door. So it can be harnessed for good. I liked one particular thing, which was actually one community, one area, I think it was in the Philippines, where they actually offered training about health services to the mayors, so that the mayors were actually more informed about what it was that was driving a good health service. We talked a little bit more about democratizing health through mobile phone technology, and the real need to have good conditions, both of work and of living, as well as just the financial rewards. So that's just a quick run around some of the issues that came up. Thanks, Nick.
Thank you, Bruce. The next group was Ahadi, Hani, James, Marcelina, Mergen, Naditha, Omar. Who would like to report back? Anybody in group 2?
Hi, everybody. I can report back. So we had quite a good discussion on these 3 questions. Time was a bit limited. So I think the first question, the key point was that there needs to be political will and commitment, which then will translate into changes in policy, so that this can become actionable. There are models that were shared in terms of healthcare workers on graduating doing community service, providing rural allowance for those healthcare workers working in rural and remote areas, and then shared care between a central hospital and rural hospital, which allows the doctor in the central hospital to spend a day per week or a week per month at a rural site. Question 2, some of the ideas was to promote private healthcare, public-private partnerships, and private healthcare institution can partner with rural hospitals or institutions, and this can improve collaboration. The other is that we should train rural doctors to keep data on the cases that they see, statistics, and also train them on some epidemiological methods so that they're able to identify the needs in the community. And then a model that was shared was a decentralized health complex, which allows rotation of students to rural sites, both undergrad and postgraduate. And you could link that to funding organizations who, so you could get higher education institutions to ensure that the research agenda includes the rural sites, and encourage funders to fund those projects that include rural sites in their applications. And then question 3 was to engage medical volunteers to do outreach to the communities and have varied forms of educational activities within communities. And the point that was made from Tanzania, I think it was that a good PHC system linked to communities, and this allows for better community engagement. Thank you.
Thank you, Mergen. Now we go to group 3, which was Andrew, Anthony, and by Randy, Ruth, Siobhan, who would like to report back?
Yeah, I'll do that. I was volunteered for that. I think we sort of talked about the questions as a whole together, and I think one of the key things coming out from the different examples was the sort of importance of training, which I think has been reflected through this conversation. As it's the most simple thing to do, but it's quite complex to enact. So taking that through, and that's across all types of healthcare professionals and all contexts. That was certainly relatable. One person mentioned around the idea of sort of formalizing training and perhaps having a diploma in rural and remote medicine as being a way to kind of ensure that, and that's certainly something in Scotland, which is my context, that I know is coming through. We also talked about, when we're talking about communities being engaged, we talked about the fact that actually decentralizing financing and how powerful microfinancing can be. So getting communities, but that leads to a kind of challenge around, I guess, some communities are going to be better able to engage with that than others, and how you cope with that can be difficult if you don't have the right people to be motivated or to take control of that. But yeah, it was mainly around training, and the sort of financing side was where we got to, which is different from what other people have said. Otherwise, we're fairly similar. So thanks very much.
Thank you, Andrew. Next group, we have Charlie, Deborah, Gloria, Jose, Malik, Salma.
Thanks. It's Deborah speaking on behalf of our group. We also had a really good conversation, and actually one of the comments that was provided earlier before I went to breakouts was about connectivity, and even in our breakout room we had difficulty with connectivity, people having to write in the chat because they didn't have access to audio. So it's sort of a basic underlying thing that needs to happen if you want to bring people together, is to have that communication capacity. For strengthening equitable advocacy, we really felt that the advocacy has to come from the front line, but it has to be integrated across other levels of, including educational programming, regulation, legislators, and policymakers, to make sure that those different groups are talking to each other to sort of really facilitate true equitable advocacy, and that there needs to be access to education and upskilling for everybody. We're aware of an organization called NextGenU, which is a global organization working with WHO, World Bank, and others, and many universities, and they're providing barrier-free, cost-free education for people. But you have to have that technology to be able to access that program. There's also disconnection between public health curriculum and what's actually happening in the field, so that needs to be rectified, and we have to engage our civil society organizations, both at country and state levels. The other thing is a solution that government should enable people who live in rural areas to be educated and empowered to be health workers themselves, and to create that sustainable workforce. So really reaching out and bringing people in from those areas where they live to actually be trained and upskilled so they want to go back and live there. For rural research, everybody acknowledged that it's very challenging, that like other people have said, and that the research agenda really does need to be coming and emanating from rural communities. So prioritizing research in public health institutions with collaboration, and we also know collaboration is challenging, but we need to partner with institutions. And there's limited funding for research. We've all seen that funding bundles shrivel and more people are wanting to do research. So it's really deciding on what kind of health outcomes research you want to do, and how do we collaborate with organizations, academic institutions, foundations, to make sure we're actually joining forces and cooperating. So recognizing that intersectoral collaboration is very complicated work, and sometimes there's asymmetrical power balances that have to be dealt with. For engaging communities, we really felt that it was important to identify community leaders, support and mobilize them to get engaged, and there has to be this establishment of trust before that happens. A lot of community leaders are hesitant at times because they don't really know what will happen in the long run. So there has to be the development of trust. We recognize it's also going to be building on local experiences, which are really important and context specific, and that we need to have these best practices shared evenly across different regions so that people have the opportunity. And again, coming back to that first comment about the connectivity, if you want to have that connection, you need to be able to have the capacity for connectivity. Great work, Group 4.
Thank you, Deborah. And so what we're getting close to time, so I'm going to ask the other remaining groups to probably keep their comments short. But we have group 5 with Andrew, Annette, Fiona, Ian, Richard, and Simone, who would like to report.
Right, I'll report. Andrew Ross here. So we didn't actually discuss the questions. Pramila talked about her experience in India and the fact that overwhelming at the moment with COVID has had a fairly devastating effect on public health in general, but certainly rural healthcare. They're seeing health outcomes getting worse in many areas, malnutrition, number of people delivered at the hospital, all of those kind of things. And recognizing that maybe this is not going to be the last pandemic that we face, just saying, how can we harness the learnings from this pandemic? You know, and someone needs to be capturing the stories of the inequality and the impact that these sort of pandemics are having, particularly in rural areas, and then trying to use those stories to strengthen the healthcare system going forward. Yep, thanks guys.
Thank you, Andrew. Next we have the group 6 with Brian, Damaris, Jeremiah, John, Jose, Dinton, Stefan.
Okay, it's Jose here, and I'm sorry that apparently I was using 2 machines and I was in another group. Very quickly, it has been very interesting, the discussion in our group. We didn't go very deep into the advocacy, but regarding partnerships and communities, these are the takings, okay? The importance of living in the communities and serving the communities to, you know, learning in both sides, and the importance of the rural assignments and the rural-based clinical schools, et cetera, as a very important topic. The second thing is we need to break the silos between education, service, and research. And there was a beautiful sentence that it came out about the research and how community will be the, we will take the it will be the sovereign of the data and the research. And this will be included in health research topics based on needs. Because one of the biggest takings of the group was that health, in many cases, is a lower priority than other social needs. And it has to be included inside of major projects of development. 8 of 10 rural areas are living in extreme poverty, and investment in basic needs is essential as I started, taking into account the Maslow hierarchy. And as a last point, is that in many places, and this was coming from Africa, primary healthcare in reality is not reaching rural communities in many cases because the clinics are far from the farms, et cetera. So the rural outing has empty pockets, and we continue talking and celebrating primary healthcare, but not implementing it. Thank you.
Thank you, Jose. So we have 3 more groups, and we'll turn it back to Michelle for commentary. So next group is Nijat, Parth, Shivagani, and Sophia.
Hi. So we had a really good discussion, and we were able to talk a little bit about each of the 3 questions. For question 1, we talked about the importance of having representation from different concerned stakeholders. We also talked about the importance of local context. And in regards to the multi-sectoral approach, we also talked about transportation as a very important sector that needs to be involved to connect patients and providers and services and other resources to make sure that everybody has access to everything that they need, especially when there are vast differences when you're encountering challenges of weather and climate, if you have to fly, if you have to travel by water. In regards to question 2, we talked about the importance of both conducting and sharing research. I gave the example, I'm from Canada, and a concerted effort has been made in Canada to develop networks of research. So for example, or even streams within networks of research that focus on the rural health workforce. For example, the Canadian Health Workforce Network does have a rural and remote health workforce stream. We've got the Center for Rural and Northern Health Research. We've got schools of rural health and medicine. But beyond those institutional investments, it's also important to really share and disseminate that research, not only conducting research with partners, but sharing them among partners. The modality of using research findings was identified as really important in forming those partnerships. And finally, the third question, involvement of community leaders and women, but also we talked about how, number two, the research could sort of stem into item 3 about community-based participatory action research. Also the formation of community advisory groups or reference groups to engage in those discussions and connecting with health professional educational institutions. That's it for us. Thank you.
Thank you, Sophia. Next groups, Anita, Elsie, Eunice, John, Mina, Pratima, Takara, and Torsten.
Thank you. We had a good discussion in our group, and some of these things have been mentioned, so I'll just outline what we discussed. That advocacy may vary from locality to locality depending on what the challenges are, but that it should be multi-sectorial. That this approach has challenges, but that's the way to go, and including all stakeholders. And we talked about transport, as the last group has said, finance, and that this should not only be left to ministries of health. And also that research and evidence is important, and we should continue doing this research in the rural communities to really come out with the evidence to use for advocacy, and also use of partnerships going to NGOs, governments, and also the community as well. And then lastly, for the community, we said that we should use the people of influence, identifying these people that can actually reach the policy makers. So if these people can gather information from the communities, but they also have influence, that will go a long way in strengthening advocacy. Thank you very much. Over to you.
Thank you, Elsie. We have Gorka, Leo, Marcelo, Majority, Mayaya, Nurhan, and Titi.
Okay, I can report on that. We have discussed about interdisciplinary in all questions, the need for us to don't just focus on doctors, but in all the health professionals. We have also talked about coping and the psychological distress that is to be in a rural area, and the need for profile and the learners, or when the training is coming, for the learner to know about risk taking even from the beginning, and also for rural health is being not the last option, but to one of the options for those that are being trained, and to guarantee that when the students, they graduate or they finish their training, they will have like a post in a rural place, not just create the expectation and then this will need to be allied with the government. This is to be very, very short, and probably I must have forgot something, but that's what for the others that haven't mentioned it yet.
Yeah. Thank you, Mayada. And our last Vinodes will report on the last group. Vinod.
Hi, thank you, Nick. Nick was there in our group. We basically, because probably we were mostly educationists speaking, we went directly into advocacy and how advocacy can be taught as a competency. And most of the time, and Prof. Knight from Australia started off actually telling us like how it needs to be included in the training of the students, the learners, and the professionals. And then we also discussed about what's the importance of leadership involvement in actually making these policy decisions to ensure that all the frameworks and guidelines created are really converted into policies and actually implemented. And at the same time, there were also discussions on how exactly that advocacy can be taught, and that actually then Erin from Canada kindly informed us regarding the undergraduate program where the advocacy is being taught. So in nutshell, yes, the leadership needs to be included, and also there are existing models of training on advocacy, which can be actually utilized to improve our understanding and awareness of these, and then probably that will actually improve our involvement and continuation of advocacy. And that was the main thing which we discussed. Nick, please add on if I missed any.
Thank you very much. And so I'm going to turn it over back to Michelle for commentary. Michelle.
Thank you. Thank you. No, this has been really, really rich and interesting discussion. And I have to say, I've never attended before, but I really, really enjoy this format with the breakout groups and the reporting back. There's a lot here on my notes, but just a few things that are resonating with me or that I'm taking from this, just so that you know, was around the advocacy side of things. I really liked the point around that advocacy is actually a competency and one that can be taught. And the other strong resonant point in here is how we ensure that voters are engaged, and that there's those voters who are the community members who are making the changes and the differences and ensuring that they're a part of this. The other part was around integrated advocacy and ensuring that the sectors, there's sort of a multi-sectoral approach to that advocacy, that it's not sort of dissecting an issue and taking just that issue, but sort of looking at things from a multi-sectoral approach, which can be very powerful. In terms of partnerships, I thought there was an interesting line being brought up around the importance of the financing links that are in there and ensuring that we're not breaking these things into silos. There was a nice quote that I'll take with me, which is the side-by-side implementation. And I thought that there was also an interesting point here made about the need for intersectoral training. So how do we actually actualize this? And what do we mean when we talk about intersectoral collaboration? Is there a way that we can train this as a competency or skill? Is really interesting. And then for communities, the needs to identify the pre-existing leaders within communities and earn their trust was really very interesting. I think that there's a huge element of trust that needs to be in here, that embeddedness element is really important. And that, the element around having advisory groups from the communities that kind of are bringing their unique perspectives. And just to end, I was writing this as everyone was speaking, and sort of something that was said before we broke out into groups around political cycles. So I was just writing, and this is one of the big things that I'll bring with me is policies have cycles, or there's political cycles, but the communities are always there. So I think that this is one of the main things to take from the conversations. Thank you again for inviting us.
Great. And thank you, Michelle, for the presentation. Bruce, closing comments?
Yeah, look, I think this has been great, Nick. It shows the power of collaboration, and I do really thank Michelle for her persistence over the last few years in getting these guidelines revised. I think the format is absolutely terrific now, and it is excellent, I think, to be a guide for at that WHO level for governments. But I think what it's demonstrated tonight too is that there's lots of good ideas in those guidelines that can be implemented in communities as well. And many of us live in communities and in rural communities and function in rural communities. And I think there's a real opportunity for us to translate those down into the communities. And I think that's all our task with you now, is to try and get this out into the communities where the voters are, where the advocacy is, where the local leaders are, and for them to be able to take these things forward in a coordinated way and a guided way, with the overview and the guidance from these guidelines from WHO. So thanks everyone for joining us. I think it's a great partnership, Rural Wonka Network, yourselves and WHO. We look forward to taking these guidelines and our blueprint together with all the other great work that's been done by Roger Strasser and Jim Rourke and many others, and make a bit of a difference over this year of the health workers. So thanks.
Great. Well, thank you, everyone. A couple just reminders. So on behalf of TUFH, we're happy to co-host this with WHO. We will have upcoming symposiums, either monthly or bi-monthly, and you can find those at tufh.org, and you can register for more events there. Everybody will receive a recorded video of this session. A reminder that TUFH 2021 is open for registration. These are all in your chat box, so you can find those. So we encourage you to register for the conference, where we'll have 4 full days of great interaction and conversations and networking. And then lastly, if you have content that you would like to share with the TUFH community, we have 2 forms. One, you can fill out the survey that is for a symposium similar to this one that you just saw. So if you have something important that the global community needs to learn about or hear about, please fill out that form and we can get you on the schedule. And then the second one is if you have a workshop that was more of a training type of proposal, we have a separate form for that one. So again, we want the TUFH community to, we are a network of network, and our primary goal is to help you share your knowledge with other ones so we can all benefit. So with that, I'll close. And again, thank you, Bruce. Thank you, Michelle. And everybody have a pleasant morning, afternoon, or evening.
Thank
Thanks
you.
all.
Thank you,
Bye,
everyone.
everyone.
Thank you so much,
Bye.
everyone. Thank you.
Thank you.
Thank you.
Bye, everyone.
Thank you. Bye bye.